how the creatinine from in the range of 10 and urea in the range of 200 plus came to almost the normal range. The case discussion. Here you can see the patient is a 51-year-old male who presented with a sudden onset renal dysfunction. He had some history of fever, some NSAID or nephrotoxic drug was given, followed which he went into anuria. When he came, this was the KFT report that was on 2nd of May. You can see urea's 276, creatinine was in the range of almost 10, 9.66 to be exact. And he had hyperuricemia and mild dyselectrolemia in the form of calcium abnormality. Here the focus is towards urea and the creatinine. Many a patient or even the medicine resident having doubt, this many urea creatinine, we have to jump into dialysis. Biopsy might be required, but depends on the history. The case, each case have its own history, each case might be different. So this case, how we managed. At first, the patient uremic manifestation was less. Second, the patient went into total anuria and there is a clear history of drug intake. Within a period of 24 hours after admission, the dialysis was initially not planned because there is no life-threatening hyperkalemia or acidosis. Only we managed it conservatively. We adjusted the volume status. The most important point to note here is diuretic was not given because the patient was volume depleted. That is why clinical examination is very, very important. As we didn't give diuretic, the patient volume status was restored back. Then patient started having urine output. Along with that, a low dose of steroid was given. Even though the biopsy was not planned. Why? Because we have to respect the patient's decision also. A biopsy is an invasive procedure. At this point of time, it is mostly a drug-induced one. Why anuria? Probably a pre-renal component was mixed in it. As the drugs was removed, the nephrotoxic drug, with hydration, with the steroid dose, the patient started responding. The urine output started coming. Over a period of next 4 days, 5 days, as you see here, patient was initially in ICU. Over a period of 3-4 days, one point to mention here is without dialysis. Yes, the patient was managed without dialysis as uremia started improving. One good point to note here is the urine output started opening up even from the 24 hours onwards as the hydration was maintained. Then subsequently, the patient was shifted to the low dependency unit. Then subsequently to the ward and the patient got discharged with a low dose of steroid. And in the follow-up, when the patient came after 15 days, the urea became normal, the T and creatinine almost on the verge of normalizing. That is why not all cases with high urea creatinine need dialysis. A proper nephrological evaluation and a proper treatment can even reduce the patient from exposing to the unnecessary dialysis. For that, diagnosis is more important and patient volume status assessment important, and avoiding unnecessary diuretic administration on situation of patient volume depletion is also the point to be noted. So the urea from this value are most normalized without dialysis. So this is the case study with respect to the value normalization of extreme high uremia without dialysis. Bye bye.